is Jennifer Woolley, and I'm the Clinical Nutrition Specialist for the Anesthesia and Respiratory Care Division at GE Healthcare. Before we begin, we want to cover a few housekeeping items. At the bottom of your screen are multiple application widgets. I'll briefly cover the most important ones. During the webcast, you can submit questions through the Q&A widget. We will try to answer as many questions as possible at the end of today's presentation. You can find answers to some common technical questions located in the Help widget at the bottom of your screen. For the best viewing experience, we recommend using a wired internet connection and closing any programs running in the background. We'd like to draw your attention to the Resources widget, where you can click and bookmark the links at any time for future reference. Lastly, this webinar recording is the exclusive property of GE Healthcare. No part of this following content may be copied or reproduced without prior written permission of GE Healthcare. Now, without further delay, I am pleased to introduce our webcast speaker. Dr. Robert Bilkovski is the president of RNB Ventures Consulting Inc. He provides strategic consulting in the field of medical and clinical affairs for medical device and diagnostic companies. Dr. Bilkovski completed his medical training at Rosalind Franklin University, the Chicago Medical School, and subsequently pursued specialization in emergency medicine. He developed clinical expertise in critical care, anesthesia and pain, cardiovascular medicine, infectious disease, and fetal medicine. Lastly, Dr. Bilkovski earned his MBA at the University of Notre Dame as part of his transition from clinical medicine to medical industry. Now I'll pass it over to Dr. Bilkovski.
Hello, everyone. And first off, Jennifer, thank you for that warm introduction. Greatly appreciate it. And I'm happy to have the opportunity to talk about metabolics today. Over the course of the next 45 minutes to an hour, this should serve as a primer to get a better understanding of indirect calorimetry, metabolics, energy expenditure, and some of the clinical use cases around where this technology has benefit. Before we proceed, Jennifer did provide a very kind introduction of me, and this is highlighted on this slide, but I do want to provide some disclosures. I am the founder and president of RNB Ventures Consulting, and I am receiving consulting fees for work with GE Healthcare. Otherwise, I do not have any financial ownerships or obligations with stocks, royalties with any publicly traded companies. On that note, let's proceed. Before we get into the basics of indirect calorimetry, let me just provide a little bit of an agenda to a level set of where we're going to go today. First off, we want to build a foundation. So the foundation is really getting an understanding of energy metabolism, or what we will be talking about is energy expenditure, respiratory quotient, as well as the principles of indirect calorimetry. From there, we'll dig into more detail around indirect calorimetry, touching on the clinical evidence. This presentation is going to be clinical evidence rich with a lot of cross-references to support the use and or the evidence for use of indirect calorimetry. We'll migrate over into the clinical use cases, touching on several, including burns in the management of the obese patient. And then we'll close off with a brief segment on the opportunities for clinical research in the future. So let's proceed. The basics of indirect calorimetry. We understand, if we start from left to right, we have mechanical ventilation. Mechanical ventilation, there's a requirement to have optimal exchange of oxygen and CO2s, or optimal oxygenation and ventilation, to be able to facilitate gas exchange. When that is compromised during hyperinflation or under suboptimal ventilation, there could be collapse. And any of those things can be affecting the oxygen exchange, and hence measurements of, say, the CO2 or VO2. Indirect calorimetry is germane to this. The reason why is that indirect calorimetry is measuring your respiratory gases, primarily oxygen and CO2. And those measurements go and inform respiratory gas exchange, primarily VO2 and VCO2. And from there, you will be able to determine through calculations that are quite convenient at this point, because they are now, there's technologies embedded either within the mechanical ventilator itself or with modules that are attached to your bedside monitors to be able to inform energy expenditure and your respiratory quotient. Those are important because they help to inform your caloric mix and the amount of total calories administered to the patient. And we'll talk about calories because being able to manage a patient through, say, resuscitation is one point, but being able to ensure that the patient has the optimal ability to be able to recover requires a focus on providing nutritional support as well. And let's not forget that this entire balance between VCO2 and VO2 for respiratory gas exchange, it's all centered around oxygen balance and oxygen delivery. Outside of the realm of indirect calorimetry, I can talk about that for multiple hours, and I have in the past lecturing around the world on this. It is important to understand that quintessential to understanding indirect calorimetry, you need to have an understanding that there is a balance of oxygen delivery to oxygen consumption, and whenever there is an imbalance between those two, oxygen that can ensue. The poster child of oxygen, that is the presence of sepsis or septic shock. So oxygen consumption, or VO2, is basically something that you'll recognize in response to changes in ventilation and or hemodynamics. The important thing to be able to measure during calorimetry is this term of steady state. The steady state does need to be established to ensure that the measurements do not have any excessive variability, and we'll go into that in later slides. Carbon dioxide on the other side, the production, is also termed VCO2. So similar to VO2, the VCO2 is a measurement that also has to be attained during steady state conditions. And VCO2 is dependent upon several things: the alveolar ventilation, so the amount of ventilation that's occurring to the lungs during the breathing cycle, and as well as the arterial CO2 content. And the blue boxes just help to give you some information with regards to the caloric implications of each of these two elements. But in summary, oxygen consumption, VO2, is the amount of oxygen that is inspired minus the amount that is exhaled or expired, and there is a calculation there. No quiz at the end, so don't need to remember the calculations, but being mindful that what comes in is oxygen and what leaves, that delta is what the body is consuming. With CO2 production, VCO2, it is the amount of CO2 that is expired minus the amount that was inspired or inhaled. So it's just the opposite. So it makes logical sense what the VO2 and VCO2 can inform. And let's move on into how does this inform on energy expenditure. At a high level, from an energy expenditure, we talk about the total energy expenditure, and there's several sub-elements that inform TEE. The REE, which is the one that we focus on at the bedside, is the resting energy expenditure, the amount of calories that you will consume or the patient consumes while nothing else is going on. The other elements are diet induced thermogenesis, so the thermal effect of food is one, and then the second one is activity expenditure. So clearly, if someone is hypermetabolic, such as in a burn situation, there is an additional component of the active energy expenditure that could be extrapolated between those individuals, if we're exercising, that's true active energy expenditure, while in contrast for burns, they're hypermetabolic, that is increasing your resting energy expenditure. It's not truly active energy expenditure, but you can get an understanding that there is a step up in terms of the caloric requirements of that patient just because of the hypermetabolic state. So I don't want to confuse that a burn patient has a higher level of AEE. The REE, or the resting energy expenditure, has gone up, but it's easier to understand if you break it down that there's a step up due to the increased hypermetabolic activity. Not going to go into the details on this, but the Weir formula is kind of quintessential to being able to determine energy expenditure. Big calculation where one of the variables is the urinary nitrogen component, and quite frequently it is often simplified because it's more difficult to calculate at the bedside, where the energy expenditure is really representing VO2 and VCO2. The steady state is your resting energy requirement, or the RER, and then built upon that is your respiratory quotient. So if you look down at the blue box to the bottom, at steady state, the RER is also equivalent to your RQ, where it is it's a division of the VCO2 divided by the VO2. So RER equals, in parentheses, RQ, which equals VCO2 over VO2. So if you know VCO2, you know VO2, you have an understanding of RQ, your respiratory quotient, and we'll go into details of what that means on subsequent slides. The nutritional assessment there, basically, the RER or RQ, if it is at 1, it implies that you are preferentially metabolizing carbohydrates. If it's less, it is informing that you're metabolizing fats and proteins, which tend to be less efficient in terms of consumption and metabolism. This is a very busy slide, but it's kind of one of the most important slides out of this presentation. If you can remember this, is that at the top line, energy expenditure, as I mentioned a couple of slides earlier, it's a summation of 3 elements: the basal energy expenditure, or the REE, the diet-induced thermogenesis, and the activity or the active energy expenditure, my apologies, to get you your total energy expenditure. The next line is your blue arrows, to give you a sense of what happens when someone sits on an RQ that goes between 1 and higher, or 1 and lower. As you go lower from 1, it is indicating that the patient is preferentially metabolizing protein or fat, which means that the patient with say an RQ of 0.8, implying that protein is preferentially being metabolized. That is also implying that the patient is having their own muscle being broken down because there is suboptimal carbohydrates to feed that patient. As you go from 1 and higher, the patient is preferentially being metabolizing carbohydrates. There is some additional information to be gleaned from the RQ, but ideally you like to straddle the 0.9 to 1.1 range to show that the patient is metabolizing food substrates in a balanced manner. As you go down into 0.8 and less, it informs that the patient, not only from a caloric intake standpoint, it may be reflecting the presence of hypoventilation, being underfed, as I mentioned just a second ago, or the patient is becoming ketotic. Quite commonly you hear people of being on ketogenic diets as a weight saving vehicle for just normal wellness. However, in the realm of critical illness, that's something that you'd like to avoid because it does induce a certain physiologic perturbations that you'd like to avoid. On the flip side, if the patient is having a RQ greater than 1.2, there is, beyond understanding that they're carbohydrate preferentially metabolizing, it could also inform that the patient is either hyperventilating or being overfed and or possibly becoming acidotic. And clearly, with the patient, you want to balance the patient from a oxygen balance standpoint, I mentioned before, from a caloric balance standpoint, and from a pH standpoint. Those are all the optimal elements that are required to ensure that the patient has a glide path for optimal recovery. Now, big caveat, this is being applied not during the resuscitative phase. You have resuscitated the patient, and now the patient is in the recuperative recovery phase, and how can you augment and improve the glide path of recovery? And that's what's important here. So the slide or the graphic to the left gives you an overarching view of what can be contributing to increased resting energy expenditure or decreased resting energy expenditure. Hypermetabolic activities, if there's pain, if there's fever, sepsis, infections, burns. These are the classic ones. Interestingly enough, male sex has a slightly higher REE compared to females, and then there's other components that are listed to the left. In the contrary, like I did say with regards to females, the obese have a tendency to show a reduced resting energy expenditure, clearly under starvation. And then the other one, an important caveat, is as you get older in age, typically 70 and older, that the resting energy requirements or resting energy expenditure goes down in that patient population. Migrate over just a little bit, talking now really with regards to determination of steady state, because to be able to get informative and clinically actionable information from your calorimeter, you want to ensure that the patient is at steady state. And what does steady state mean? Several key points. You haven't changed the ventilator settings for within the past 1 to 2 hours. There is no assertive nursing interventions such as tracheal suctioning, washing, wound debridement, etc. The patient, from a temperature standpoint, is stable. Hemodynamically, the patient is stable. It's not like all of a sudden you started the patient on a dobutamine infusion or the like because of hemodynamic perturbations. Because those hemodynamic perturbations, remember, boil down to balance between oxygen delivery and oxygen consumption, which then feed into VCO2 and VO2 that the calorimeter measures. So if DO2 and VO2, or oxygen delivery and oxygen consumption, are in flux, that can then cause issues with regard to the robustness and the reliability of your indirect calorimetry measurements. I'll just summarize with regards to the blue box. At a minimum, ensure that there's at least 5 minutes of steady state. Ideally, 10, 20, 30 minutes, and local institutions have embraced different practice patterns, but typically the literature is focused somewhere around the 10 to 20 minutes to ensure that steady state, and then you look at your calorimetry outputs for VO2 and VCO2 and ensure that coefficient of variation is small, less than 10%. Getting it closer to 5% is ideal. However, it's much more difficult, realizing that these patients are dynamic. So there's always an understanding that there's going to be some level of change that occurs minute by minute. Some other considerations around indirect calorimetry are the limitations. Understanding where the calorimetry measurements may not necessarily be robust. Clearly, leaks in the circuit, it's dependent upon ensuring that your circuit is closed or tight. So you want to make sure that there's no leaks within the ventilator circuit, around the endotracheal tubes, or even at the patient level if you have a chest tube and there's pneumothorax or something along those lines. We talked about hemodynamic shifts before. The reason why, like I said, with regards to balances or imbalances between oxygen delivery and oxygen consumption. In general, indirect calorimetry tends to wane in terms of its accuracy and robustness as you go beyond an FiO2 of 60%. Clearly beyond 80%, the literature shows that it is unreliable. So be a little bit more cognizant with regards to looking at your calorimetry outputs when the patient is cresting through that 60% FiO2 range. And then lastly, looking at reducing humidity and condensation within the breathing circuit itself. So that was the foundation, and now we'll go into some of the clinical evidence to kind of bolster the argument of the necessity of indirect calorimetry compared to other means to measure nutritional status. So the first is nutritional support. I mentioned this just a few slides ago. Nutritional support is ideal to be started within the first 48 to 72 hours. That is when resuscitative phase has ended. The patient is kind of out, is quote unquote out of the woods, whether or not that is within the first, say, 24 hours of burn management, of sepsis management, or trauma care, or post-cardiac surgery. You get the picture. So ensuring that the early nutritional support, primarily enteral, has been deemed to be proactive to reduce issues with regards to disease severity, reduce complications, decreasing length of stay, and then there's favorable impacts on patient outcomes. And the source is McClave. With all of these talking points are cross-referenced by the articles themselves. And from a nutritional standpoint, Bartlett showed that there is a 3x higher mortality percentage in the surgically critical care patients when their energy deficits, cumulative energy deficits, exceed 10,000 kilocalories. So clearly, these patients, those that stay in an ICU for 7 days or longer, it's not unfathomable to be able to achieve 10,000 kilocalorie deficits if you're only feeding the patient 500 calories a day. So clearly, there's some implications in the surgical intensive care unit. Same thing has been associated with increased days on mechanical ventilation and lengths of stay. And typically, there's a relationship between nutritional optimization and decreased ventilator days, as well as hospital stays. So if you can reduce the time on the ventilator, it naturally extrapolates to being able to reduce the duration of stay in the ICU, which then also reduces the hospital length of stay. And then with regards to the use of indirect calorimetry to optimize nutrition, I'll just quote, it says, it has become clear that both overfeeding and underfeeding are harmful and that optimizing nutrition to patient-specific needs is an urgent task. This Zussman quoted that, and they tout that calorimetry is the way to go. And then Pierre Singer, who's very well regarded in this space, has touted the utility of indirect calorimetry on multiple encounters with regards to the robust and reliable measure of energy expenditure. The reason why they talk about indirect calorimetry and not predictive equations, there's innumerable predictive equations. Most of the predictive equations are not accurate. There's a compendium of evidence here from Zussman and Graf that show that there is quite a large disparity in terms of the accuracy of predictive equations, whether that's the Harris-Benedict or the Penn State or others that just do not hold up against a broad range of patients to be able to inform their nutritional status and their caloric needs. And then from a timing standpoint, I did mention earlier about 48 hours to 72 hours. Oshima here in 2007 showed that 3 to 4 days following ICU admission is the optimal time. There are some other bits of evidence that are suggesting that even closer to 48 hours is a good time to start evaluating nutritional status, because it's a double-edged sword. You have to ensure that the patient is hemodynamically stable and they've recovered, so you don't want to go and base caloric targets based upon unreliable indirect calorimetry outputs, but you also don't want to wait too long, because then the patient is developing a nutritional deficit, so they're shifting into ketosis and then further aggravating their homeostasis. And then there are other technologies. So I'm clearly here speaking on behalf of GE Healthcare, but there is innumerable other technologies out there. Two of them, CCM by Medgraphics and Cosmed that has the Quark RMR. There's newer versions of their technology that also provide bedside indirect calorimetry. This one article showed that both of them were not as robust compared to some of the more gold standard, which is the legacy device is the Delta Track from GE, but that has sailed off into the sunset. There is newer technology out there, but be it as it may, indirect calorimetry evidence is growing and continuing. I've just recently completed a systematic literature review between 2019 and 2021, and there's at least 40 articles that are focusing on a handful of different technologies for indirect calorimetry across a broad swath of patients. So there is utility across all of these different devices. And then outcomes are driven by making sure that you can tailor or goal direct nutritional status. Overfeeding is a problem. Overfeeding has been associated with increased risk of infections, carbon dioxide production, which can affect your ability to wean, prolonged lengths of ventilation. Underfeeding, on the flip side, it's going to result in the patient losing lean body mass. It's going to be more difficult for them to have their own strength and capabilities to A, get extubated, B, gain muscle tone to recover and ambulate. So all of these things point to ensuring that you can optimize nutritional therapy to be able to prevent the risks of underfeeding as well as overfeeding, which both are associated with increased length of stay and unwanted patient outcomes. And just at a high level, this is kind of my use case of being able to get a sense of how to implement calorimetry within your critical care practice. First, you take the patient and you assess the eligibility and where is there evidence to support that indirect calorimetry is informative. Several are listed here. Then the next part, which is important, is to ensure that the patient is at this point of steady state, or they're likely to be at steady state, and then start being able to evaluate their steady state status, and then be able to obtain information with regards to calorimetry. Like I said, sampling times of 5 to 20 minutes. 20 minutes better because you're eliminating more noise, and then from there you extract the information, the VCO2, VO2, to be able to get your RQ. If the RQ is less than 0.8, typically you are underfeeding the patient. The patient may have other issues present, such as ketosis. If the patient has an RQ greater than 1.2, it is suggested that you are overfeeding, so you'd like to tailor or trim down the total caloric intake, and then you also may want to reevaluate the balance between carbohydrates and fats in terms of their nutritional support. And clearly, all of this is not done in isolation. This is part of the team. You'll talk with your nutritional support staff, which will be quintessential during these calculations or during these deliberations. And then ultimately, based upon the resting energy expenditure, you're not aiming for perfection. You're aiming to hit 70% of energy expenditure. And typically, if the patient is below your RQ target or above your RQ target, what you will do is you'll do step increments of 5 to 10% up or down, respectively, depending upon whether or not you're concerned of overfeeding if you are concerned of underfeeding and or overfeeding. And then you'll do a daily reassessment until the patient stabilizes and can be able to no longer need nutritional support. They're extubated, they're talking, and now they have the ability to ambulate. There is no need at that point. The patient is in the next phase of recovery that is outside of the critical care space. Let's move on into some clinical use cases, and also leveraging some of the clinical evidence that helps to support this. At a high level, this is something that came from the ARC practice guidelines years ago, but it's still quite relevant today. Indirect calorimetry, the poster child or the prototypical use cases are, the critically ill, mechanically ventilated, those that are obese or malnourished, risk of malnutrition, the surgical patients, and the trauma patients. What are commonalities? There's deviations of normalcy in all of these patients. They're being mechanically ventilated. That's not normal for the patient. They're now dependent upon a ventilator to provide oxygen and ventilation support. That does cause perturbations to their homeostasis. The obese have a deviation in terms of their resting energy expenditure compared to the non-obese patient population, and self-explanatory for the trauma patients. That also includes burn patients and the surgical patients. They've been exposed to a stimulus, wanted or unwanted, that is now causing significant deviations in their metabolic needs. Let's focus on burns. It's probably the place where there's been exhaustive research around the use of calorimetry. It's been shown, if you look at the graph to the left from Clark, that burn patients have a exaggerated metabolic response. I've said that before. This is the literature that supports it. It's not only exaggerated in its magnitude, but it's also exaggerated with regards to its duration. So these patients have a long hospital course. Clearly, there's always concerns around just managing the burn itself, but the nutritional elements associated with burn patients has put the utility of indirect calorimetry front and center in this patient population. And the primary goal of nutritional support, as Clark touts, is to basically to fulfill the caloric requirements caused by this hypermetabolic state, and more importantly, to risk overfeeding the patients. And that is where indirect calorimetry is considered the gold standard, because the predictive equations in general have been suboptimal in being able to identify what the actual or the true energy requirements are, and then based upon that, even if you apply a 70% of goal, you are going to be underfeeding these patients if you're using or leveraging predictive equations. And then Moreira here, the one thing that I just wanted to illustrate is that the methodology of calorimetry is not just a one-time fits all. You apply it on a regular basis. Daily seems to be the most appropriate. I've seen less than daily, even every shift. There hasn't been that much information that can inform changes in nutritional care on a per shift basis. So leveraging what Moreira touts is a good place to start as the prototype for calorimetry, where it will be daily measurements and then reassess the patient's daily caloric needs. No different than what we do if we're tracking our calories. If we're fitness enthusiasts or on a weight loss program, we like to track our total calories, track our macros. We do that on a daily basis. We don't adjust per lunch, breakfast, and or dinner. It's at a daily basis. Next, cardiac surgery. Interestingly enough, a lot of these patients, when they go into cardiac surgery, are identified to be malnourished. And then those that are malnourished, DeWell is another author that has done a fair amount of publications, primarily from the Kokokos trial compendium, that those patients that are malnourished going into cardiac surgery have a higher in-hospital mortality and then increased length of stay. So clearly, being able to have a prophylactic view of nutritional status in a cardiac surgery patient can reap benefits in reducing patient morbidity as well as hospital lengths of stay, which provides not only clinical benefits but economic benefits to your facility. And then on the flip side, the RQ does have the ability to predict outcomes in cardiac surgery patients, where in this one studied by Piot, the RQ was higher than other non-survivors, and it was found to be statistically significant. So the RQ is informative of risk in and of itself in this patient population. Migrating over from the cardiac surgery patients, you have the polytrauma patients, and once again, Petkova here showed that the RQ was negatively correlated with both ventilation times and ICU lengths of stay. So clearly, as that RQ is going beyond 1.2, which is unwanted, it is negatively affecting the ability of that patient to be extubated, have the appropriate nutritional status or milieu for recovery, and that translates into increased lengths of stay in the intensive care unit, which is a very expensive environment. So there are clinical implications and economic implications associated with this. And once again, Petkova here touts that an RQ close to 0.8 is considered the goal, and anything under 0.7 is suggestive of underfeeding. Pediatrics, another area where the patients benefit from indirect calorimetry. Another example of where the predictive equations fall short. Aspen guidelines in 2016 have touted their use that energy expenditure with indirect calorimetry is recommended. In that the estimation or use of predictive equations of these patients could falsely over or underfeed the patients, and we've already talked about what are the detrimental effects with regards to over and underfeeding. If you look at the second column, just another proof point showing that predictive equations in these pediatric intensive care unit patients are suboptimal. So clearly, at a high level, indirect calorimetry is your way to go. Trying to avoid leaning on predictive equations, even if you don't have indirect calorimetry, we understand. Know that if you are going to be using the Harris-Benedict or others, know that you're dealing with imprecise information, and ideally have means to be able to try and risk stratify patients to identify where and when you can use calorimetry-based technology to optimize care of your patients. For the sake of brevity, I'll migrate over into talking about obesity. I mentioned that before, that the obese patients have a tendency to have lower resting energy expenditure compared to non-obese patients. So therefore, if you use predictive equations that have been based upon normal body weight individuals, clearly there's a risk that you are going to overshoot their caloric needs in that patient population. And Oshima once again touted that these predictive equations are just not that good for the obese patient population. And the articles also to the right just help to further support that argument that predictive equations are not that informative and can result in rather noticeable deviations of targeting caloric needs. Martinez on the bottom, if you look at mortality alone, those that had suboptimal nutritional delivery based upon predictive equations resulted in patients having worse hospital outcomes as well as mortality. And quite commonly, the predictive equations were less than 1/3 of true energy requirements. So once again, another example here, at least of 3 articles that are touting the importance of leaning on indirect calorimetry to drive your nutritional status assessments of your obese critically ill patients. And then more dear to my heart, because I was a sepsis researcher for many years, there is also evidence around the use of indirect calorimetry in sepsis. Similar to burns, similar to trauma patients, these patients are hypermetabolic. There is an overwhelming inflammatory response. That is why the patient is having the manifestations of sepsis or septic shock. And then there was the first article to left, Panichot, basically was just looking at the use of determining the robustness of predictive equations versus calorimetry. Once again, poor agreement was identified between the predictive equations and calorimetry. There is some evidence looking at VO2, just being able to measure oxygen consumption in patients, that there was a difference in oxygen consumption between the groups of septic patients versus non-septic patients, which makes sense. Oxygen consumption should go up in a patient that is septic. That means that they are hypermetabolic. Could this be useful to gauge resuscitation of patients in the future? That has to be further elucidated, because I've touted for the past 30 minutes establishing and maintaining that the patient is at steady state is important. So how do you ensure that a patient is septic and being resuscitated, you're obtaining VO2 and ensuring that they're at steady state? Perhaps you do do periodic measures and you do signal averaging over the course of 30 minutes, an hour, or 2 hours to be able to inform what is your oxygen consumption over a slightly larger aggregate of time of several hours. And then the flip side is resuscitating the patient is one thing, but getting them off the mechanical ventilator is also important. And there is use of looking at energy consumption during the process of weaning, and then there has been some evidence that shows that patients that fail weaning trials have a higher energy expenditure, which is to be expected because it is a greater level of stress on the patient. But once again, another area where there are shoots of opportunity to further understand the use of calorimetry in evaluating patients that are going through weaning assessments, whether that's spontaneous breathing trials, TPs, or the like. And then lastly, talking about the elderly patients. Didn't go into excessive details here, just highlighting that there's several articles that are looking in patients that are elderly, 70 years of age, 80 years of age, and just similar to other patient populations that were illustrated during this presentation today, that predictive equations are suboptimal in this patient population as well. Once again, the elderly do not fit the norm for where predictive equations were based on, just like obese patients weren't. So indirect calorimetry is ideally suited for these elderly patients, especially as you're cresting beyond 70 years of age. Now, changing gears and migrating into the home stretch here, looking at opportunities for further research. I touted a little bit during the sepsis section that there is information to be gleaned with regards to oxygen consumption. You are measuring VO2 at the bedside in real time. There is the opportunity to be able to go and glean whether or not these measurements of DO2 and VO2 can be utilized during the processes of weaning. Still, it's in the infancy, but it makes logical sense that a patient that is going through a spontaneous breathing trial, and you can evaluate calorimetry based upon VO2 and also VCO2, but looking at these measures to be able to look at changes pre and post spontaneous breathing trials and identify whether or not there is ability to further augment prediction rules that predict extubation success. There are some other areas that have been just touched on primarily at abstract level that hasn't completed peer-reviewed literature. Looking at the prognosis of cardiac arrest, I think it's probably a little bit more robust than that, but the utility of that use case is, I'd say, a little bit more finite, but clearly looking at the implications of VO2 in managing the sepsis patient, not only during the golden hour of sepsis and or trauma, but during what's affectionately touted the silver day of sepsis and trauma care. I think that is an opportunity for further evaluation. And then on the VCO2 side, like I touted at the beginning of the presentation, it all boils down to ensuring that you can have adequacy of gas exchange, which means that you have adequacy of alveolar expansion, not over distension, and not alveolar collapse. So leaning on VCO2 to inform whether or not you can infer around lung recruitment, not only in ARDS, but in blunt thoracic trauma, to identify those patients that are at risk of developing propagation of worsening lung function. I didn't include it, but it makes plausible sense also because a subset of ARDS is in the COVID-19 infected patient population. The patients that become hospitalized and deteriorate quite commonly will manifest an ARDS-like clinical picture. So are there opportunities to leverage VCO2 in terms of predicting escalation of, deterioration of your COVID-infected patients? Granted, in spontaneously breathing, you have to not use an inline methodology. You'll have to use a hood to ensure that your circuit is as closed as possible. But there are opportunities to further glean whether or not indirect calorimetry measurements, VCO2, VO2 on their own, or RQ and or REE are informative of being able to further tailor care in this patient population. And on that note, I'm closing. So on that note, I'd like to close out this presentation by reflecting on what we talked about today. This 45 minutes serves as a primer to have a better understanding of indirect calorimetry, the fundamentals from a physiologic standpoint that inform the measurement of VCO2 and VO2 and how they drive towards understanding the caloric needs of the patient as well as the caloric balance of the patient. Furthermore, being able to understand the prototypical clinical use cases, the obese, the burn, the septic patient, the trauma patient, the cardiac surgery patient, all have a robust evidence of literature that shows indirect calorimetry compared to predictive equations is much more informative to be able to tailor nutritional therapy to those patients, because there's robust evidence that shows overfeeding and underfeeding both are associated